Okay, thank you very much, Dr. Alia, for inviting me, and also to the faculty of the university. It's a real privilege for me to be here, and I very much appreciate the kindness and your hospitality. My talk today is going to be about retinal vein occlusion, because I think it's probably one of the hardest conditions we would treat as a retina specialist. And it's a very interesting disease. Sorry, can we go back a few slides? Yes. So retinal vein occlusion is it's very common in Australia. It's more common than we think, and I think it's actually more common in Indonesia compared to Australia because of the incidence of diabetes being higher. In Australia, the risk of having a retinal vein occlusion, whether it's central retinal vein occlusion, so the retinal vein occlusion, whether it's branched retinal vein occlusion, central retinal vein occlusion, or hemiretinal vein occlusion, is quite common. It's a very important cause of sudden vision loss in Australia, and it's a very characteristic picture when you look at the eye into the retina. You will see hemorrhages. You will see hemorrhages along the distribution of the retinal vein. And classically, it's described as being nerve fibre layer hemorrhages because it's very superficial in the retina. And in this slide, I've illustrated three types of the vein occlusion. There's branch retinal vein occlusion, hemiretinal vein occlusion, and central retinal vein occlusion. What are the risk factors for retinal vein occlusion? So there are many, but when I teach registrars or residents or I give talks, I think there's really only two main causes of retinal vein occlusion that we should all remember. The first is high blood pressure or hypertension, and the second one is having glaucoma or raised intraocular pressure. All the other risk factors that I've included on this slide are in some ways anecdotal, so there's not a lot of strong evidence for it, but certainly for hypertension and glaucoma, those are the two risk factors that are modifiable that we can treat. Sorry, I'm having a bit of trouble with the slides. Okay. If we look at central retinal vein occlusion, there has been a lot of excellent histology studies that have looked at why do people develop central retinal vein occlusion. And as Dr. Alia would tell you, who does a lot of research on optic nerves, that you have actually what's called a physiological narrowing in the optic nerve head behind the lamina cribrosa. And that is often the site where you will get a thrombus forming in central retinal vein occlusion. There are two reasons why you might get a thrombus there. One is because there is a pressure gradient between the brain and the eye that falls across the lamina cribrosa. The other is because there is actually a compression by the arterial circulation on the retinal vein at the site of the lamina cribrosa. So for both of those reasons, you can get a thrombus forming and a subsequent retinal vein occlusion. And this is work actually which we did in our laboratory in Australia, where we looked at the retinal vein in normal human eyes, and we actually showed that the endothelial cells become very narrow. They almost look like arterial endothelial cells at the lamina cribrosa or just behind it. And that's exactly the site where you will get a thrombus in a retinal vein occlusion. Now, so I'm just going to focus my talk on ischemia in central retinal vein occlusion, because I think it is the most important thing that will decide if someone has long-term vision loss. It's the amount of ischemia that they have. And classically, when we looked at central retinal vein occlusions, we used to divide it into ischemic and non-ischemic central retinal vein occlusion. With a lot of the imaging we have now, that differentiation is not so important. But ischemia is certainly a very important feature in central retinal vein occlusion, and It is also something that we can treat with laser, something that we can treat with anti-VEGF therapy such as Avastin. And I'm just going to talk about how we can utilize those tools and those management strategies to manage patients to get better visual outcomes. And remember, if you have ischemic central retinal vein occlusions, you're at risk of rubeosis on the iris and risk of neovascular glaucoma. And some people will get vitreous hemorrhage if you don't detect these changes early. And I think over the last 10 years, the descriptions that we use to describe retinal vein occlusions as being ischemic and non-ischemic is changing very quickly. And that's largely because of the new technologies we have. So I'm just going to start by talking about how we used to define retinal ischemia using fluorescein angiography. Then I'm going to talk about OCT and OCT angiography and how we use that in clinical practice. I'm going to talk about anti-VEGF therapy or intravitreal therapies for treating retinal ischemia. And then I'm going to talk about PRP, pan-retinal photocoagulation. Can we use that to reduce the treatment burden of anti-VEGF therapy in vein occlusion? So classically, the way we used to evaluate retinal ischemia was using fluorescein angiography. And if you looked at the literature of retinal vein occlusion, one of the very first reports to define central retinal vein occlusion was this paper published in 1992, where they used fluorescein angiography to differentiate ischemic from non-ischemic central retinal vein occlusion. And this is basically a cut from the paper, so I copied and pasted what they used. So if patients had good dilation of the pupil, those were the 4 or 5 segments of the retina that they studied to define something as being ischemic and non-ischemic. As you know, many people that have central retinal vein occlusion will not dilate very well for different reasons. And if they didn't have good dilation in this particular study, which we use very commonly, they only looked at the regions around the optic disc and the macula, so predominantly the posterior pole. And what they said was that retinal vein occlusion was ischemic if you had more than 10 disc diameters of non-perfusion. And this was decided by two graders, and then they used those findings to determine if they correlated with long-term vision loss. And this is what they found. They found that in this study, if you had less than 30 disc diameters of non-perfusion on the angiogram, the risk of actually developing a complication is actually very low, which is very interesting because when we talk about retinal vein occlusion, most people talk about 10 disc diameters. But if you actually go back to this landmark study, only, if you had 30 disc diameters of non-perfusion or less, your risk of developing retinal neovascularization is very low. So that's very important to remember. However, if you had more than 75 disc diameters of non-perfusion, then your risk of developing retinal neovascularization was more than 50%. So those patients needed treatment of some sort, and some of them ended up having vitrectomy surgery as well. So now things have changed because we have much better technology to examine the patients and to evaluate the retina. And one thing that has really changed the landscape of retinal vein occlusion management is ultra-wide field imaging. So this is the Optos imaging system. And this actually allows us now to look at the entire retina from the ora serrata from one side to the other. And this is an ultra-wide field image of a patient with a central retinal vein occlusion. The thing about this, as you will see, is that if you went on the previous classification of central retinal vein occlusion, this would actually be classified as a non-ischemic central retinal vein occlusion. But if you looked at the ultra-wide field angiogram, can you all see that in the far periphery there's no perfusion of the retina? So this is in fact ischemic. So this is one example of how Optos imaging or ultra-wide field imaging has changed central retinal vein occlusion. The important thing to remember about central retinal vein occlusion is that the non-perfusion and the ischemia starts in the periphery and it works itself towards the center. The other thing about using fluorescein angiography in central retinal vein occlusion is that often there is so much bleeding that you can't grade if an eye is ischemic or non-ischemic. As you can see in this particular case, you've got two different patients who have the typical blood and thunder central retinal vein occlusion, and you won't be able to see too much on the angiogram. The other thing about the fluorescein angiogram is that if you do the angiogram at baseline, you may get a very false overview of whether the eye is ischemic or not. So this is a patient that had an angiogram and they developed a retinal vein occlusion, and then 1 month later, and you can see at the 1 month later they've developed significant non-perfusion. So the timing of doing the fluorescein angiogram is also very important. So what are the limitations of fluorescein angiography? So if you looked at the fluorescein angiogram, and this is a very good fluorescein angiogram in a young, healthy patient, if you compared their fluorescein angiogram to histology, what you're seeing is, this is a study we did in our laboratory where I looked at human donor eyes after they died and compared it to their fluorescein angiogram. And you can see that the histology looks very similar to the fluorescein angiogram. But what I'm actually showing you in this patient is that the histology presented here is only that of the superficial plexus. So the deep plexus, which I've shown you at the bottom, is actually never seen on the fluorescein angiogram. And that's a very important point to remember as clinicians, because when we have conditions such as diabetic retinopathy or retinal vein occlusion, it's the deep retinal circulation that is often affected first. And that is often not seen on the fluorescein angiogram, as I've just shown you. So what are the new techniques for evaluating retinal ischemia? So OCT, I think, is the most important tool we have as a retina specialist or an ophthalmologist for examining the retina. So, if you compare the OCT to histology, you can see that it's remarkably similar. The advantages of OCT is that it is very fast, so it takes about 3 seconds to acquire an image. It's very safe, it's reproducible, and it's non-invasive. And this is what a typical OCT looks like. Now, using OCT, we can define retinal vein occlusion in a different way. And I'm just going to go through the two different classifications of retinal vein occlusion using OCT. So this is a video. Sorry, can you play the video of the fluorescein angiogram, please? So this is a real-time video of a fluorescein angiogram being performed in a patient with a central retinal vein occlusion with a visual acuity of 6/12. And you can see that the transit of the fluorescein through the retinal circulation is delayed, but it's not terribly bad. And the patient has a visual acuity of 6/12. Can we go to the next slide, please? Now, this is the ultra-wide field fluorescein angiogram of the patient. You can see that the optic disc is hot. The blood vessels are staining with fluorescein, but there's not a lot of non-perfusion of the retina. Can we play the OCT video? So this is the OCT of the same patient. So this is an OCT volume scan running through the retina. And have a look at that very carefully. So you'll see what's called a PAM lesion on the OCT. And the PAM lesion stands for paracentral acute middle maculopathy. So I've just compared a normal OCT to a PAM in this particular slide. And you can see that in the PAM lesion, you've got this band of hyperreflectivity on the OCT. And what that signifies is that the ischemia is not the entire retina, it's just the middle plexus of the retina. So it's a different type of non-perfusion or ischemia than you would normally consider. Now, I just want to take a step back and talk about the retinal circulation, because as you would all know, the retinal circulation is not one plexus, but it's actually 4 different layers of plexus which are localized to different layers of the retina. So if you took a cross-sectional histology, which I've shown you here, you will find that you have one plexus in the nerve fiber layer, one plexus in the ganglion cell layer, and then one plexus on either side of the internuclear layer. And what PAM represents is that it's a selective ischemia of the intermediate and deep capillary plexus. And this is seen in about 5% of central retinal vein occlusions. Most of these patients have non-ischemic central retinal vein occlusion, and they typically have a better outcome. Okay. Now there is a different type of So I just want to go back to our case. Oh, sorry. So I just want to go back to our case of our patient that presented with vision of 612 with a PAM lesion and just some delay in retinal filling on the fluorescein angiogram. And this patient never received any treatment, but their visual acuity slowly improved over time to 6/9. So you can see that even though the retina appears quite thin on OCT, the visual acuity is actually very good. So you can see the PAM lesion has collapsed and it's actually looking a little bit better. And on the thickness map, you can see that the PAM lesion, when it collapses, the retina becomes thin, but the visual acuity surprisingly is good, and the fluorescein angiogram is also demonstrating evidence of reperfusion of the retinal vein at 12 months. Now there's a different type of ischemia, which I'm going to show you now, which is different to PAM. Now this is a patient that also presented with a central retinal vein occlusion. You can see there's lots of retinal hemorrhages in all 4 quadrants. The optic disc is swollen, the retinal veins are tortuous and dilated. And this is the OCT on this particular patient. You can see that there is a lot of edema of the macula, but if you look at the inner retina where those red arrows are pointing to, there's actually a lot of increased reflectivity, very different to the PAM lesion I showed you before. And that's very similar to what you might see in a retinal artery occlusion, where you see a lot of increased reflectivity of the inner retina. So when you see that increased retinal reflectivity on the OCT, those patients typically do much worse than the patients that have PAM lesions. So in this particular patient, I treated them with intravitreal therapy, but after 12 months of treatment, they are only seeing 6/18, even though all the macular fluid is gone. So I'm going to talk now about OCT angiography, because I think that's the latest technology that we are exposed to as ophthalmologists. And what OCT angiography is, it's just simply an extension of OCT. So it's just applying the same technology in a different way. And it's an excellent technology because it's unlike fluorescein angiography, you don't have to give contrast. So it's very safe, it's very fast, and it's non-invasive. And most of the commercial devices now will have an OCT angiogram platform. And I understand that you have a Zeiss OCTA at the university, which is excellent. And this is an OCT angiogram of the macula. This is actually my macula, so it's quite normal. But you can see how nicely you can see the macula, you can see the foveolae vascular zone, you can see the very fine capillaries of the retina, which you couldn't see before with fluorescein angiography. The nice thing about OCT angiography is that you can look at all of the different layers of the retina. You can look at the superficial plexus, the intermediate plexus, and the deep plexus. So that's one advantage that it has over fluorescein angiography, is that it has depth resolved information. And this is the OCT angiogram compared to a fluorescein angiogram in a patient with a branch retinal vein occlusion. You can actually see that the OCT angiogram shows non-perfusion much clearer than the fluorescein angiogram, because the masking of the blood doesn't interfere so much with the image. In a central retinal vein occlusion, this patient has non-ischemic central retinal vein occlusion, and if you look at the macula on the OCTA, you can appreciate that. If you compare this image to the last patient with BRVO, you can see that there is a big difference. In this patient, you can see that the macular perfusion is actually very normal, so they're likely to have a good outcome. So I did a study which I published 3 years ago where I looked at OCTA characteristics in patients with diabetic maculopathy and maculopathy due to retinal vein occlusion. And there's actually a very strong correlation between the size of the foveal avascular zone and the visual acuity in these patients. So I think it's very useful when you see these patients to do an OCT angiogram to look at the macula, because if they have a very big foveal avascular zone with lots of perifoveal non-perfusion, then they're likely to have limited visual acuity in the long term. So in this study I showed there's really only 2 indicators of long-term visual outcomes. One is whether you have disruption of the ellipsoid zone on OCT, and the other is whether you have an enlarged foveal avascular zone. You can actually apply OCT angiography now in a very nice way to make 3-dimensional images of the retinal circulation. And this is a lot of work was done by a doctor called Rick Spade in America, who I worked with in New York. And I'll just show you, this is actually an OCT angiogram of a patient with macular edema due to retinal vein occlusion. So I just want to remind you, sorry, just go back a little bit, thanks. So, yeah, that's fine. So I just want to remind you that this is non-invasive imaging. So we didn't have to give contrast to get this image. So this image was developed within 3 or 4 seconds of acquisition. And I'll just break this image down for you so you understand what's going on. So there's 3 different colors on this image. The teal, light blue color is for cystoid edema. The red color is for the superficial plexus of the retina. Sorry, the red color is for the deep plexus and the blue color is for the superficial plexus, okay? So this is an OCTA image acquired from a patient when they presented for the first time with macular edema due to retinal vein occlusion. Now look at what happens after we treat them with anti-VEGF. So one intravitreal therapy, and I just want you to pay attention to the fact that the macular edema is gone. So it's very effective, the anti-VEGF therapy has worked. But in both images you can see that the perfusion in the superficial and deep plexus is still there. So the area where there's no blood vessels has persisted. And this is 4 weeks, so now there has been recurrence of the macular edema. And the interesting thing here is the macular edema has recurred in exactly the same spot as at baseline. So, you know, we basically concluded from all those studies that macular edema tends to form in areas of the fovea where the capillaries are non-perfused, and that's shown very nicely in this image. So I just want to talk about a few things, just a few concepts in terms of managing retinal vein occlusion. Because we think about central retinal vein occlusion as a condition where you have to treat them with intravitreal therapy, where we have to sometimes treat them with laser, and then sometimes have to treat them with surgery, vitrectomy surgery. So what's the evidence that we have for this? So one very important question is, if we treat someone with anti-VEGF therapy, like Avastin, the macular edema gets better, but does the retina perfuse again from that treatment? So I just want to talk about that, because that's an important concept. So this is a patient, 85-year-old patient who presented with a central retinal vein occlusion and with macular edema. Okay, and can we play the video on this patient, please? So this is the fluorescein angiogram. If you wouldn't mind just playing the video, please, on the slide. Oh yeah, good, thanks. So just pay attention to how long it takes for the dye, the fluorescein, to get into the retina in this particular patient. So this is real-time imaging with fluorescein. So look at how slow that fluorescein is to get into the eye. So just based on that, you will get some impression that this patient has a very ischemic retinal vein occlusion. Even before the angiogram is completed, in my mind I know that this patient is at high risk of neovascularization. And this is their wide field angiogram. So you can see there's lots of leakage of fluorescein in the peripheries, the optic disc is hot, the retinal vessels are staining, and there's capillary non-perfusion. So this patient I treated with anti-VEGF therapy, and I gave them 5 injections, and their vision went from 615 to 660. And even though all the fluid has gone. Can you play the video? So this is the fluorescein angiogram after 6 treatments. So this is the same patient, okay? So 6 months afterwards, and what do you notice? It's actually worse. Look, the perfusion through the retina is even slower on the fluorescein angiogram. So just for the residents, it should take about 2 seconds from the dye to get from the retinal circulation into the venous circulation in a normal person. So in this patient, it's taking about 15, 20, 30 seconds. It's a long time. So look at this patient. So even though I've treated them with intravitreal therapy, their non-perfusion is getting worse. The capillary non-perfusion is actually working its way towards the center. So what should I do? Well, I went back and had a look at the literature to see, is there any evidence that injecting with intravitreal therapy improves the perfusion of the retina in central retinal vein occlusion? And in fact, there was a nice paper done by Peter Campiciro from America, and he showed that only 8% of people that get intravitreal therapy for central retinal vein occlusion will have better perfusion of the retina after treatment. So anti-VEGF therapy does not improve reperfusion, it only treats the macular edema. So what I did for that patient was I thought, well, should I treat them with pan-retinal photocoagulation now? And that brings up the next question. Does PRP reduce the risk of macular edema in retinal vein occlusion, and does it reduce the treatment burden? So if I give someone laser with central retinal vein occlusion, do they require less injections of anti-VEGF therapy for their macular edema? So this is the same patient. This is a different patient. So presented with a central branch retinal vein occlusion, 660 vision with macular edema, and that's their fluorescein angiogram. 660 at baseline, gave them 5 injections and they're 660 still, even though the macula is completely dry on OCT. Could you play the video, please? So I've started the video midway through the angiogram, but you can see that in this patient there is a very slow transit of the dye through the retina. So, even after 2 minutes, the retina hasn't filled. It's that slow. So what I did was, I did an ultra-wide field angiogram and showed that it was very ischemic, even after treatment with 6 injections. And now what's happening is they're becoming resistant to anti-VEGF therapy. So when we try and stretch the treatment out, even when we stretch the treatment out to 2 months, there's more fluid, and now when I'm giving it to them every month, there's still more fluid. So what do I do now? I treated them with laser, okay, to reduce the VEGF drive. Oh, sorry. Can we go back a little bit, please? So I treated them with pan-retinal photocoagulation, and that didn't do anything actually. They still had lots of macular edema, and it was becoming very unresponsive to anti-VEGF. So finally what I did was I treated them with steroids. So lasering the retina in retinal vein occlusion, you would think would reduce the amount of injections you need to give someone to reduce for their macular edema, but it actually has no effect on macular edema. So in retinal vein occlusion, I really want you to think about it as 2 different processes. You have retinal ischemia and macular edema, and they're actually quite independent. So treating one doesn't often help the other. So in this particular patient, what I did was I treated them with a dexamethasone implant, and the macula became dry, but their vision was still very limited. And I think that's really the conclusion of this talk. And really, I was asked to talk about retinal vascular occlusion as an emergency, but I think over the last 5 years in practice, I've learned that it's actually a very difficult condition to treat. A retinal vein occlusion in every single patient behaves very differently. And it's very important to look for the complications which will affect their vision. And the two things we look for is macular edema and macular ischemia. We have a lot of new technology to help us look at those complications, the main ones being OCT and OCT angiography. And I really do hope you use the OCT angiography more, because it's actually a very useful and excellent device. And I just want to highlight that, and I hope I've shown you with some cases that treatment of macular edema and retinal ischemia can be very challenging. And sometimes you have to give them injections and laser to get on top of it, and sometimes they can still have very bad visual outcomes. So once again, I'd like to thank you very much for inviting me for the talk, and if you have any questions, I'd be very happy to answer it.
Thank you, Dr. Chandra. We still have enough time for discussions, so please, if any of the audience bila ada pertanyaan, bisa disampaikan secara langsung mungkin. Dr. Nadia, gitu.
Dr. Chandra, it's very nice presentation. I would like to ask if I want to do the OCT angiography for the peripheral vascular in the retina, because we know that OCT angiography is specifically for macula, but in like BRVO, we want to know the multi-layer analysis of retinal periphery. So sometimes we have difficulty to make the tracking of the eye compared with conventional OCT. So do you have like trick or tips for tracking the peripheral retinal vascular in OCT? Yeah.
I mean, it's a very good question. It's actually very challenging, but with the OCT A that you have with the Zeiss, you can actually get quite far into the mid-periphery. You won't be able to get into the far periphery. It's just not possible.
Yeah.
But with the Zeiss platform, if you use the 6x6 millimeter cube or the 12x12 millimeter cube, for a branched retinal vein occlusion, you'll see the non-perfusion and what you're looking for very nicely. But it is, if you want to get very far into the periphery, the technology is not quite there yet.
Yeah. It's still difficult, right?
Yeah, I think they're developing new things. I think in the next 5 years they'll probably be able to image out there.
Yeah.
But right now, no. It's tricky.
Yeah. Okay, thank you.
Thanks.
Thank you very much. Any other questions? I have a question, Dr. Chandra. We highlighted that ocular emergencies, the time factor is very crucial. In your experience, does it have a significant prognosis if this occlusive vein occlusion is discovered early, or if it comes a few weeks or days later for the outcome for the patient?
That's a very good question. I think the studies have shown if you treat earlier, the long-term visual outcomes are better. So if someone presents with a central retinal vein occlusion or a branched retinal vein occlusion, if they don't have macular edema, there is no point treating them. You don't need to give ocular therapy because it's too early to apply laser because you won't know how much non-perfusion there is. So the acute management in those patients is to make sure their blood pressure is not high and that they don't have high intraocular pressure as a risk factor. And then what I do is I usually see them in 2 or 4 weeks, because what I'm looking for in those patients is macular edema using the OCT. A lot of those patients, when they present with normal macula at the first visit, will develop macular edema at 4 weeks with a reduction of vision. And then I would treat those patients. If I saw a patient with a retinal vein occlusion with macular edema at the first visit, I would give them intravitreal therapy. And I would start that treatment every month, initially until the macula is dry. Once the blood has cleared, I will do an angiogram, and then I'll decide how much non-perfusion there is based on that.
Thank you very much. Dr. Seskawati, please.
Thank you, Dr. Chandra, for the nice presentation. Sorry I'm late, but as we discussed before the session, how can the OCT can help us to evaluate the ischemic and the optic nerve in the acute phase and chronic phase? And maybe you can suggest us maybe any ancillary test that we must perform to evaluate the blood flow in the retinal artery centralis. Thank you.
Sure, that's a tough question actually. So, OCT angiography only provides an image at a single time point. So that is a big limitation. So people say that OCTA or OCT angiography will provide functional information. I don't think that's true with the technology we have. Because as you can see from all the images I showed you of the OCT angiogram, you have beautiful images of the circulation, but it's a fixed image. All you're seeing is the structure of the vessels. When I look at a patient with retinal vascular disease, like a vein occlusion or diabetes or an artery occlusion, when I do the angiogram, I usually acquire a movie, as I showed you.
Like video.
Because I like to see how the dye is traveling through the circulation, because that gives us a lot of useful information. Because I hope you appreciated with the last two cases, the transit of the dye through the retina is so slow, you don't really need any other information. You can tell the patient that their retina is very ischemic. So their chance of a meaningful visual recovery is limited. So to answer your question as to how do I assess flow in the retina, that's the main way I do it. It's not with OCTA. Now, we're doing a lot of research trying to use lots of different OCTA images and compare them to look at how flow is derived. But that's very experimental, and there's a lot of limitations for doing that. I think in terms of how can you apply OCTA in clinical practice, I think you will find, particularly in patients with diabetic retinopathy, if you see them every 6 or 12 months and you do an OCTA, you will find that the macular ischemia is expanding. Their foveolae vascular zone is enlarging, they're losing more capillaries in the macula, which is actually a very important sign of macular ischemia progression. And that's important because a lot of those patients will have recurrent macular edema, and they can also require intensive intravitreal therapy to control their edema. So all of those things in terms of counselling the patient and developing expectations and long-term visual outcomes, I think OCTA is very useful for that. So I tend to use it a lot. Yeah.
Thank you.
No problem.
Thank you for the questions. Dr. Nadia, another question. Final question.
Okay, thank you. The problem is in this country is sometimes the patient always came late. So in CRVO patient, they always came with bad visual acuity and very large ischemia and very late. So, and the insurance cannot cover the anti-VEGF and they don't have money or something. So we know that actually from evidence base that PRP is already done if there is a neovascularization, but sometimes I do it the PRP anyway because so what is your opinion about it?
I agree with that. I think that's a very good idea because if they don't attend, they're at risk of rubeotic glaucoma. I don't think you have anything to lose from giving the laser. So in Australia, we have people, Indigenous Australians, Aboriginal patients, which they don't live in the city. They would live 3 or 4 hours away. And it's a very similar situation because they may attend very late or they may not come to the appointment at all. So for those patients, I would do exactly what you said. So even if they have bad vision, their macula, their retina is ischemic, I would give them PRP to reduce the risk of rubeotic glaucoma, neovascular glaucoma. I don't think you're going to achieve much by doing intravitreal therapy.
Yeah.
So I think I would do exactly what you said for those patients.
Okay, thanks.
Yeah.